Now, I'm going to move on to talk about meningitis, another very important cause of headache. So I'm going to talk about the clinical features, how the patient presents, the key investigations, and the management. So what's the underlying pathology? Well, meningitis, as the name suggests, is an itis, inflammation of the meninges, usually as a result of infection. Bacterial meningitis is what I'm going to focus on, but other causes of meningitis include viral meningitis, TB meningitis, HIV, fungal, and malignant meningitis. How does the patient present? Well, the typical presentation is of someone who becomes rapidly unwell, and this can be in a matter of hours or even minutes. The patient will have a severe headache of pretty rapid onset. They will complain of the symptoms and signs of meningism, so neck stiffness, photophobia, fear of bright lights, vomiting, fever, and they may have seizures as well, and if it's severe, reduced level of consciousness. On examination, when you see the patient, they will be extremely unwell. They'll have a fever, tachycardia. If there is associated septicemia, they may be in septic shock. They may have this typical petechial purpuric rash if there is associated bacteremia, although I should stress that the rash is caused by meningococcal septicemia, not by meningitis. So a patient can still have meningitis, but without the rash. And in contrast, the patient can also present predominantly with septicemia, but without the meningitis. So the two are actually separate entities. They may have a rapidly deteriorating GCS, and on examination, they might have positive Koenig sign, and this is pain which the patient has when the knee is extended with the hip flexed, and that's caused by irritation to the meninges. They may also have signs of raised intracranial pressure. In an infant, this might include a bulging fontanelle, or they may have papilledema or loss of retinal venous pulsation. But again, I should stress that these signs are not always 100% sensitive, and you shouldn't really rely on them clinically. So the key investigations: full blood count, renal function and clotting screen, blood cultures which you want to take before you give antibiotics, lumbar puncture, and you may want to do a CT scan before you take the lumbar puncture to exclude raised intracranial pressure, and I wouldn't rely on the physical signs of papilledema, they're not always reliable. And a chest x-ray as well to see if the patient has got a chest infection. Now, lumbar puncture is contraindicated in raised intracranial pressure, as I've said, because of the risk of coning, the reduction in pressure dragging the brainstem down. And as I said before, papilledema and retinal venous pulsation or lack of it are not 100% sensitive. So you should do a CT head scan to rule out raised intracranial pressure. And unfortunately, I don't have a scan with me, but what you're looking at are areas of the ventricular system in the brain which indicate raised intracranial pressure. So you can look at the craniocervical junction, that is where the brainstem, the base of the brainstem, to see if there's any herniation of the cerebellum. Look at the third and fourth ventricles, and they should be present in midline, normally. Look for CSF around the brainstem, and if you can't see any, you have to wonder whether the cisterna magna has been obliterated. And even CT scanning is not 100% sensitive. Now, how do you actually do lumbar puncture? Well, I won't go into the details of the actual procedure, but the anatomical landmark is the iliac crest. If the patient is in the left lateral position, it's the iliac crest. And that is in line with the L3, L4 space. And the reason why you want to go there is because that is below the ending of the spinal cord. And when the needle goes in, it'll just disperse the nerves from the cauda equina, and there's no risk of damaging the spinal cord itself. So once you've managed to get in to the space and you're draining CSF, first of all you measure the pressure, and then you collect your sample. And this slide is very important. This looks at what you actually look at in the CSF to determine what's causing the meningitis. I'm going to go through bacterial and viral. If you suspect TB meningitis or fungal meningitis, there are other things you can look for, but I'll just focus on bacterial and viral. And there are three main things you look at. You look at the glucose, protein, and what cells are present in the CSF. Now, on macroscopic examination in bacterial meningitis, sometimes the CSF will actually look cloudy and turbid, and then you'll probably know instantly when you get the sample the patient has bacterial meningitis. But on microscopy, the cell type which predominates are neutrophils, in contrast to viral meningitis, where predominantly you get lymphocytes. The glucose in bacterial meningitis is low, whereas typically in viral meningitis it's normal. Protein isn't always helpful because it can be raised in viral meningitis and usually raised in bacterial meningitis as well. Further tests you want to do are a gram stain culture and sensitivity to determine the underlying organism causing the bacterial meningitis. And if you suspect viral meningitis, then PCR to look for herpes virus. Other important point is that when you send the sample off, you should also send a paired serum plasma sample with it in order to have a comparison against, because you're looking at the comparative value of the glucose in the CSF compared to the blood. Now, what are the important microbes which cause acute bacterial meningitis? Well, the three which you ought to remember really are Neisseria meningitidis, which causes meningococcal meningitis, Streptococcus pneumoniae, and Haemophilus influenzae B. And there are now vaccines available for all of these, well, for certain subtypes of strep pneumoniae, but certainly for meningococcal and Haemophilus influenzae B. Other rarer causes in those who are immunocompromised or neonates include Group B strep, E. coli, Listeria, and TB, but I would remember the top three. Those are the most important. Now, if you take nothing else from this lecture, just remember that it's a medical emergency. The patient will deteriorate rapidly. So what do? You resuscitate the patient, make sure they have a patent airway, start them on oxygen, and establish IV access, and then give IV antibiotics. Now, you want to give a broad-spectrum antibiotic, and this will, exactly which antibiotic you use will depend on which hospital you're working in, but broadly speaking, a third-generation cephalosporin, something like ceftriaxone. IV fluids, analgesia. The role of steroids is contentious. Personally, if someone asks you about the management of meningitis, I wouldn't mention steroids, but there is some evidence to suggest that if you give steroids early on, it can reduce the complications of meningitis, things like deafness, by reducing cerebral edema, but it's quite contentious. The other key thing is don't wait to give the antibiotics. Don't wait for the lumbar puncture, because if you wait, the patient could be dead. Take the blood cultures, and that will at least give you a sample. But if there's going to be a delay in lumbar puncture, for example, because the patient needs a CT scan and there's some kind of delay getting them through the CT scan, then don't worry. Give the antibiotics and you can take the lumbar puncture afterwards. So in summary, someone who presents with a headache and a fever, you must rule out meningitis. The management, broadly speaking, is resuscitation and antibiotics, and don't wait to give the antibiotics. Don't wait for the lumbar puncture. Okay.